today's webinar. We are continuing with the World Patient Safety Day series, which has been like a series of webinars where we've been discussing patient safety. The theme for this year's World Patient Safety Day has been diagnostic safety. So we've been mostly talking about diagnostic safety. Today, we are going to narrow down and talk about diagnostic safety in children and how we can enhance it. And just before we start, I'd like a question and answer session. We'll have one at the end of after the speakers speak. So feel free to drop in any questions that you have at the Q&A portion that's just below down the screen. All right. So we have two speakers today. Our first speaker for this session will be Christine Mutena. She's first and foremost very passionate patient advocate. She's also the founder of an organization called Rare Disorders Kenya. And the organization is actually a patient-led organization that seeks to create awareness, especially in Kenya, concerning the rare disorders that we have. She's also a founder of another organization called Step by Stones, which is like a support system. She can tell us more about it, but it's supposed to be a support system for parents and special needs parents. She's also spoken in various platforms. She's spoken concerning just the rare disorders that are found around and just how to manage that. And specifically, she's also spoken at the 78th UN General Assembly, which was held last year. And she's a phenomenal woman. So I'm excited for us to hear from her. Karibu sana, Christine.
Asante. Do I start? Do we wait? What do we do? Dr. Mary?
Yes, Christine.
I was asking, are we starting now, or are we waiting for anyone?
No, we'll start right now. We have
Okay,
quite a number of people, so we can start.
No problem. Thank you for the invitation. Thank you for giving me this opportunity to actually share my story and how it has grown from a small mom in a house trying to fight for the rights of her kids to something global. So I will start my presentation. I will be quite brief. I won't follow exactly what the slides are because it's a lot to say. It's about something ranging from 18 years of experience. So that's what we'll be going through. I'll be discussing diagnostic safety in children, my journey. Can you see my slides?
Yes, we can, Christine.
Perfect. So I did not study medicine, disclaimer, should have had that slide up. I actually have an undergrad in computer science. It's just that my career path was thrown a curveball when I got my kids because they both have different rare diseases. And I had to choose between my career and my motherhood. So that was when the patient advocate called Christina was born. Next slide, diagnostic journey. As I told you, I have two kids with different rare conditions. The first one has a gene mutation that is currently clinically undiagnosed, but as research has been done by her mother, she is known to have a gene mutation that causes her syndrome. So what I've done over the years is try and figure out what does she have, because she has a myriad of symptoms that together form a certain cluster of conditions called PIK3CA gene mutations. So I believe she has that, but we are yet to get a clinical diagnosis, which entails me taking a sample of her tissue and sending it to France for analysis, which will probably take around 3-4 months before I get a yay or a nay. My second daughter, I was diagnosed at 2 years old. She has a rare chromosomal anomaly. And the reason why she was not diagnosed at birth is because we were looking for the condition that the firstborn had. And we got to miss it because the secondborn had something totally different. If I was to speak on the diagnostic challenges of the firstborn, there was lack of health literacy, especially around what she had. The doctors, when some of her symptoms were diagnosed at birth, but they could not correlate and combine them to lead to a certain diagnosis. So on discharge from the hospital, we were not told this is what is the problem or this is what you need to look out for. We were just told, here's your child, go home and be happy. So that was a diagnostic challenge because we did not know what we were dealing with or how dire the consequences were. Then there's a lack of understanding from the healthcare providers in the sense that also they didn't know what that was. So I cannot honestly, I can't blame them. It's just that as a parent, you just want what is best for your child. So lack of understanding from the conditions actually from both my end and the healthcare providers. Then there was a lack of local genetic diagnostic tools. My child turns 18 in January. So that was 2007. So there was no genetic discipline in Kenya then. There was no genetic counselor, let alone a geneticist. So it was like literally me being thrown into the deep ocean, not even the deep end of a pool, in the sense that I didn't know where to start. The doctors didn't know where to start if you start looking for genes. So like nowadays, when I look at my fellow parents, they have access to gene mutation. They have access to gene diagnostic tools, whether it's local or abroad. They have two geneticists in the country. They have a lot of healthcare providers, doctors in training, us training the genetic discipline. So there's so much going on for them that I didn't have when my kids were growing up. Then there was no multidisciplinary team in the sense that she had congenital hydrocephalus, and then she also had hemihyperplasia, but those two are not put together as could be the reason for something bigger. So in the sense that when I used to go to the neurosurgeon, I used to be sent home after clinic. Then I have to go to the neonatologist for something totally different. And the only time those two doctors or those two disciplines were engaging is go and do this. And then after that, come back. Not why are we on the same table. And then there's no local condition specific support group for my kids, both of them, especially the first one, given that it was a rare condition and I didn't know what was going on, neither the doctors. So I had to look for a support group abroad to help me navigate this path and let me know how I could have the day-to-day hacks of how to deal with or how to manage my child's condition. Come baby number 2, we're not told that she had dysmorphic features at birth. As much as she did not have a good APGAR score, some of these things were not told the urgency of it all, like literally what it means. So those global developmental delays in the sense that she was late in sitting, she was late crawling, talking, etc. But we're not told how important that is, that we need to monitor. We were referred for testing by an occupational therapist who asked me, she told me, I think your child has Down syndrome. And I remember I was in the office and I'm like, I don't think so. I think that's different. But you see, given that my firstborn had a condition that you still can't tell, I could not ignore and say the occupational therapist was just being mean. So I had to go to my gynae to request for a test for what you could do to check for the Down syndrome. And when we did the karyotype, the results were sent to me, not even the doctor who wrote the note. And I remember in the office calling down, reading the results, and at the bottom it said genetic counseling required. And I'm like, where do you even start? There's no geneticist I could go to. There's no counseling. What does this imply? So for me, all that, receiving all this information firsthand and not it being broken down to my level of understanding, did not help my mental health. Then there's also, again, lack of a disease-specific group support for daughter number 2. Remember, we have 2 different diagnoses here. So those are 2 different support groups that were both not available in the country. And up to now, I still have not met any other person living with that condition in the country. Then some of the patient-centered diagnostic solutions I think we really do need in helping patients understand and be part of the diagnostic journey together with the patient healthcare providers is shared decision-making, for starters, whereby I need to know that I need a buy-in. The patient needs to buy into the treatment plan, into the management plan, such that I'm not being told what to do, but I'm being asked, how can we do this? So this is what you need. So being part of the table, not the old practice of doctor telling the patient and the patient doing what the doctor said. At least let us understand, why is this important for me? Why is this paramount to me following it to the letter? Because I suspect most of you have patients who don't finish medication because they felt better, but they did not seem to understand why they have to finish the doses, especially in the situations of antibiotics and the antimicrobial resistance that's rampant. Then interdisciplinary communication between all people, all the stakeholders in that patient's life, ranging from an occupational therapy to the physician, to the parent, to the family members. That should be something that's discussed so that at least the patient knows everyone is there for them. Then there's this patient-family engagement, cultural competences and diagnostics, whereby if I come to your clinic and I do not understand what you're telling me, and if I ask a question, I'm not explained for in layman terms, then I will feel like this is just not part of my life. But so it's easier if, as practitioners, you sit us down and talk to us at our levels and help us understand what is going on with our bodies or our loved ones' bodies, so at least we can understand and empathize and be for their patient completely 100%. Then diagnostic transparency, that's something I need to discuss very well, because for me it affected my patient journey with my kids, because I was not told this is a diagnosis. But once I was told this is what is happening, I was not told how important it was. She had congenital hydrocephalus, and it has brought a myriad of subsequent issues that I was not explained to or told to watch out for when I was told to go home and be happy. And for me, that worries me a lot, because if I had known, for example, like she would have intellectual disability, I would not have taken her to mainstream school and tried to force her, like the same way, like you have a left-handed, you're trying to force them to write with the right hand. It would have been easier for me to know, okay, this is a situation you might have to deal with, so this is the best way to deal with it. So at least we're not what do you call it, the opposite of preempting. We're not reacting to a situation, but you're actually being proactive before it actually happens. Then the biggest discussions we've had around rare disorders and rare diseases with our members and patients is that there's always this diagnostic loop whereby the patient is taken round and round and round. You're looking for malaria, but every time you do the malarial test, it's negative. You still do the malarial test again, as opposed to upward referral or referral to your colleagues or a multidisciplinary team, whereby okay, it's not malaria. Let's try something else. Let's try to, or take them up the referral chain. So at least they can feel less frustrated. They can feel like there's an active purpose to try and figure out what is wrong with them. And also that you're not, I'll be frank and tell you how we feel. We're not just being put in a loop, so at least you can, doctors can have a constant patient, but us guys just want to get healed. So if you cannot find the problem with us, kindly forward us to somebody else. Then, so from this, I have learned that I'm lucky for the parents of today because they have a different diagnostic journey than I did. If I compare to 2007 and 2024, whereby there's a pediatric geneticist, there's an adult geneticist, there are so many labs that do genetic testing, and they are more than happy to give counseling where needed. So for me, I find that as much as I struggled, as much as it was hard for me to put one foot in front of the other, I'm actually proud that the parents behind me, the patients behind me are actually having an easier journey because it is hard. And coming from a parent, and those who are parents, you know, you do anything for your child. If they ask you for a biscuit, for example, you work hard to give them that biscuit. So learning and knowing that life has evolved in Kenya in terms of healthcare and genetics is a very good thing for the current parents and also for our children's children. So out of all this, and as Dr. Gitao has alluded to the fact that I have many hats, I founded an organization called Step by Stones Association, which was to be a local support group for parents of kids with different disabilities. Because when my kids were diagnosed, I did not know of anyone else. I still don't know of anyone else locally, but I needed to feel like I belonged in a group. And all those groups that were currently available were disease-specific groups or condition-specific groups. There was like cerebral palsy, there was autism, there was Down syndrome, but unfortunately, I did not feel like a part of that because their journey was not my journey. Then came a time a few years later where I co-founded Rare Disorders Kenya, which is a patient-led organization that creates awareness and advocates for persons living with a rare disease in the country. And that came from, or that was born from a sense of knowing that there are other people out there with a rare disease. Why don't you create a group, a peer-to-peer support group that will enable others to know the journey may not be the same, but the journey, the condition may not be the same, but the journey is the same in the sense that you're feeling alone. You're feeling like no one knows anything about you. You're feeling like an outcast. You're feeling that no one understands you because you're not the norm. And from there, I'm going to discuss a bit about Rare Disorders Kenya, RDK as we call it. And this picture depicts, I think it was 2018, where we were celebrating Rare Disease Day, which is a global day for celebrating people living with rare disease, creating awareness, talking to policymakers, government, stakeholders, industry. And we were meeting just to celebrate and say, yes, we do exist. We may be few in numbers, but together we're collectively big. And some of our objectives include educating and raising awareness around rare diseases, improving lives of people living with rare diseases, collaboration with different stakeholders like Ministry of Health, industry, as I'd say, international stakeholders, just to make a difference and improve the quality of life for a person living with a rare disease. And then the last objective, which is something that unfortunately is yet to kick through in the country, is promoting research. Because a lot of research has been put into communicable diseases and a few on non-communicable diseases like cancer. But given that you fall under NCDs, you find that research for rare diseases is too costly because a lot of Stakeholders will ask, where is the return on investment? Where are we creating a $2 million drug? Who's gonna buy it? And probably the people affected by that $2 million drug is a handful. So for us, that's one of the disadvantages, but we are here to promote research. Then something else, these are some of the photos we had for different rare diseases. You can see we're all happy and making merry and celebrating us and our children and our family members, because at the end of the day, we are not alone. So as you read this quote, I want to reiterate on the importance of diagnosis, because early diagnosis leads to early intervention of and management of the patient, which leads to better results. And as a patient advocate, I would like to emphasize that patients do not want to, we're all under for the same goal, for a healthy patient, for an easy quality of life, because rare diseases don't have all treatment. Actually, 5% of rare diseases have FDA approved treatment. So 95% are just managed cases. And we are here to just hold hands and just work together and see what best we can do for the patient. So if you ask me how can we collaborate, I would say, if you get a patient with a rare disease, whether or not you can get management or treatment for them, it's a holistic management plan. So send them to a support group where they can get assisted psychologically, physiologically, and just to know that there's someone else out there who understands them. Because I do believe as humans, we're not meant to be alone. We're not meant to be feeling like we're the only ones on this earth. So that's why we're all supposed to go. And that's why I like this proverb that says, if you want to go fast, go alone. But if you want to go far, go together. Thank you. Dr. Gita, I hope I did not rush through.
No, thank you so much, Christine, for your presentation and just sharing your experience with us. I'm sure most of us might not be very familiar, or it's not something we really think about when it comes to, for example, rare disorders. So thank you for sharing your experience with us. Allow me to just ask you maybe one question or two before we go to the next speaker.
Okay.
So when it came to like the diagnosis and just and you mentioned that the firstborn the diagnosis is not yet found, and you say the second the diagnosis came from an occupational therapist pointing out some changes and just maybe the need of genetic testing. So maybe if you could highlight at what age were your children diagnosed, and how you felt, especially when the breaking down of the information concerning the rare disorders. How was that experience for you? And did you finally get to talk to how did you go about it? Did you at that time talk to a gene therapist, or how did you go around it?
Okay. My firstborn turns 18 in January, and she's one who's clinically undiagnosed. But some of the symptoms were presented at birth, but there was no follow-up, or there was no one trying to see if all these were just part of a syndrome. Secondborn was diagnosed at 2 years of age. She's now 13. So it's been 13 minus 2 is 11. It's been 11 years of trying to figure out, okay, what next? But luckily for the physicians that deal with my case, I think God decided I've had enough. Let me throw in a few blessings. Is the doctors I deal with do understand that I may know more, because I research on this one particular condition, and I have access to different patients across the globe who have different treatment plans that I can share with my doctor. Like, for example, I remember the second one, a lot of members in that chromosomal group were saying, check for thyroid, check for thyroid. So I told my doctor, I think we just need to start checking for thyroid. And lo and behold, she has a thyroid issue. So it's these small things that we request our physicians or our children's physicians, is that let us be able to share the knowledge you've gotten from abroad or across this network or other patients, so that at least you can live better and live quality of life. And then the other question about how I felt is alone. I felt like I had been disappointed to some extent because I didn't know anything. I was just a mere young mother trying to raise a child. But if you look at me now, people ask me, have you done medicine? Have you done this? Because I have been compelled to learn more and dig more so I can help my doctor, help my daughters. So it's not easy. And it's not everyone who gets to have a rough ride, because I know one of my colleagues, a child was actually diagnosed in utero. So as I said, it's getting better, but as much as it was a rough ride for me, I'm not regretting, because I think from what I learned, I have been able to teach those behind me how to navigate the journey.
All right. Thank you so much for just sharing the experience. I think it's very important for all of us to just almost familiarize ourselves with what you could be feeling. And you've mentioned also a very key point of just having the healthcare providers come up with that shared decision making, where they understand that you might also know a lot more than they do, given the situations that you're in. So thank you. Thank you again for
Thanks as well.
the experience. We'll just move on to the next presenter or speaker. We'll welcome Dr. Okutoi for a brief, to just give us a brief concerning what diagnostic safety really is, and just a bit about diagnostic safety specifically in children. What are the special challenges that can hold, and what solutions do we have? Dr. Okutoi.
Thank you very much, Dr. Mary. I hope you can hear me.
Yes, loud and clear.
Great. Thank you, Christine. Mutema, once again, we are truly delighted to have you. Last time you came for our patient and family-centered care symposium, and indeed, it was our first time to encounter you and the work that you're doing. And so mine is not really a presentation, but just to give some highlights from what you have shared in terms of what are we picking from what you're saying when diagnosis is delayed. So one of the definitions of diagnostic errors is when we have delayed or wrong or missed diagnosis, while the other side is the aspect of, is that diagnosis communicated to the family. But in rare disease, it comes to a point whereby by nature of what is required, maybe the test, maybe the level of acumen, clinical acumen, or the doctor being aware that this could be leading to that. That's why a physiotherapist, having seen a similar child, is the one who's prompting you that could your doctors follow up on this? So rare disease are prone to a delayed diagnosis, and many rare disease families encounter a miss or a wrong diagnosis because at times we do not accept that we are truly lost. So one thing Christine said is share with the family, share with the patient where you are at. This is what you're thinking, but it is likely or unlikely because they're also reading. Remember, for her, she's had these children that she will read about. She will look at every other symptom and try to connect. So actually, you become the expert. The patient is the expert of their condition, and they bring to the doctor opportunity to make sense from what the patient is saying, together with what the lab side is trying to determine. And I'll decide a genetic test because of the history. you'll decide to go for a radiological tests because of what you have heard from the patient. But now in rare disease, you have this patient who maybe for the last 2 or 3 years, in fact, some have a mean age of 6 or 5 years before making a diagnosis. Luckily nowadays, there are other tests that are more available, even some within the country. But that time is an opportunity to have the other things that Christine has talked about, the community, having opportunity to be with people who are able to understand what is happening. And so what is the role of us as a facility, as hospitals? It is to be able to, first of all, in a patient-centered way, understand that we are not yet at that level of having understood what this diagnosis is, or we think because it has ticked this box and the other, it is likely to be ABCD. So it means that the aspect of communication, it is not only the power distance of the doctor knows that the patient is just listening. When it comes to rare disease, it is a collaborative effort. And these patients come and they deal with our systems, at times requiring multiple tests, at times requiring care just for the symptoms. You know, when Christine was presenting, she was presenting with a symptom. Maybe she's gone for physio to strengthen the muscle, or some will go to the ENT. So they go to multiple spaces. So how are we prepared to support those with rare diseases as they come for care within the system? And in a referral hospital, what does that mean? At primary care, because at times we think that some support is easier at a lower level. There was a patient who came to us and said, actually, I have like about 4 clinics. And so in a year, I cannot even afford to go to all of them because I have to support mobility for my son, and I have to pay, and I don't have that money. So the challenges are varied and multiple. And so the aspect of the community and the aspect of the system being prepared to work with that patient. Who is the system? The system is how care is organized, but at the same time, we who work in those facilities, we understand how easy or difficult it is to access this care and what are the opportunities of health. We may be the ones who know that there is a community called rare disease. This mother who is just coming and getting a genetic diagnosis doesn't know. So even up to the patient advocacy groups are part of the system. How we finance health also helps them to either access or make it difficult. And so primary healthcare actually is an opportunity for support, especially for patients who present with multiple systems and symptoms that require support from different players within the system. And the individual care that they so require, be it nutritional, be it physiotherapy, be it now going to the cognitive side and supporting to going to school. What is the need of this patient? And so depending on what they're presenting with, there is what is urgent, but as Christine said, she discovered, oh, my child would have challenges in a regular school. So that should be part of a one-stop clinic to be able to offer the information that for this, you go to the other. We have a neurodevelopmental clinic in KNH, and we were asking ourselves, how comes at times it takes so long? We have a lot of, no-show, or 50% of people who are booked at times do not come. And so we're asking ourselves, how do we create value? Of course, those are not typical rare disease, but it's just the support that families need when they have children with such condition. We have to create value for whatever need they have as we organize the care system. Another great thing which Christine brings is the aspect of advocacy. She has learned beyond her personal pain to the journey she's gone through to now supporting the others. And that is now the advocacy means that she's able to articulate some needs, be they at levels of testing or of care, which with the voice of the patient, it becomes a powerful tool. And so Christine, allow me just to say that what you're doing is truly powerful because it brings hope to somebody who will see that I can identify with you and I can relate in how challenging it has been to get care, how expensive it is, and also the aspects to do with research. And so my take-home point as on the side of the clinical side is to accept to be vulnerable enough and to share with the patient what we are trailing or what we are tracking in terms of making a diagnosis, and what we have ruled out, what is known, and also to leave it open in the event there's something that develops, because rare diseases have some intermittent or short-term symptoms, and at times they recur again, and it can take a while for them to be established. So if we do not listen to what the patients are coming with and their families, what they're observing and how they are reacting to our treatment, then we may not be able to go to the next level. And so when we determine the goal of care, we may just be addressing the symptoms, not knowing the underlying disease. So just to acknowledge that indeed that is the case. I was in a meeting recently, and they were talking about equity in making a diagnosis. When we are lost, how much blood can you take from this one patient to test for everything? And can the patient say they want a rest or a break? Because it's true, we don't know, but will you do all those tests? Will you do all those radiological from one MRI, one CT scan? So as much as would want to get a diagnosis, the patient-centeredness aspect of ensuring that we are doing just what is sufficient and not having money at the back of our mind. Because remember, all these diagnostic tests are expensive. I'm sure Christine can mention the number of families who are just putting together funds for this next test and this next test. And remember, they're not sure whether it will even give them the answer. And then diagnosis is one thing and care and support is another. So there are two folds kind of strain. And so we need to walk that journey in a humane way, and not just putting someone aside because they cannot afford. Let us make sense of, okay, so with our resources, what kind of tests are we able to do, and what are they able to give? So it means with rare diseases, the doctor needs to disclose and be able to share and be able to open to feedback from the patient, because you work together. The tests are not cheap, but at the same time would want to find a diagnosis, and at the same time would want to support the care. I think that is the few comments that I can give, and just would ask Christine maybe to give us some highlights on in her group, what are these things she can tell us as healthcare providers in terms of the such patients accessing the care and the diagnosis, and in referring to the system at the different levels. Have they found value also in the primary healthcare? I'm so sorry, I'm at a noisy place.
It's
Thank
okay
you.
because we can't hear the noise, so don't worry.
Okay, you're welcome, Christine. Thank you.
Thank you. We found that at primary healthcare, it's just more or less the symptoms that are diagnosed, but as you go up the level of referrals, then it gets better. The only problem is, and to be honest, our referral system for the public healthcare in the country is quite slow. So by the time the person is getting to, for example, KNH, the condition has quite increased or progressed. But a lot of our members actually come through us from the private healthcare because they worry about being given through the diagnostic loop by the doctors and not being pushed up. And you find that with a rare disease, once it, okay, 72% are genetic and start in children. So by the time a child is born, if it's not figured out from onset of birth, then by the time the child is like 1 year, 2 years, and they're missing the milestones, but parents are easy to look for ways to help the child, not like before when we used to sit and be told, oh, that happened in the family. Our family is always slow in learning or slow in talking, and you just sit down and and wait for their child to speak. So what has helped is, as much as the referral system is trying very hard to catch up, the patients or the generation that we're dealing with right now are people who are open that diseases do exist. They will not hide their children. They will look forward and try and see what is wrong. So even some of our members find us online and they say, I was looking for this because my child seems to have a condition that cannot be told. Or if they get a diagnosis, they go online and they search and say, oh, there's a support group. How can you help me? Is there a similar patient? So it's different across the country, but in terms of healthcare system, I think it's much better. I would not complain if my kids were born in this era, because things are way, way better than how it were before. I don't know if I've answered your question.
Yes, thank you very much, Christine. I think using that social media and using the online presence makes it more accessible. I guess you get consultations from across, even beyond the country. And so thank you. That is a good digital tool. And I think having the vehicle with the right name, rare disease disorder, then it is possible anybody could find out the kind of support. You've also mentioned the issue of primary healthcare, that at that time, the diagnosis is rarely made on the public side, but more of in the private. Yeah, because by the time they come to Kenyatta, maybe they have gone round and round with other attempted diagnosis. But I think the essence of an effective healthcare system is that care is given where it is most accessible, and then also matters of cost, that if we strengthen primary healthcare, then we're able to pick. So I think the aspects of communication and just finding out what is happening in this place and how can you get from that level 3 to the level 4 and to the next. If our diagnostic tests would be available, that should make it easier. But there is the aspect of the support and care where a diagnosis has been made. I'd want you to comment about the support and care, like for the ones with, let's say, rare disease genetic disorders with neurodevelopmental support. Is there any role that such services, whereby the review, they can have it in the tertiary institution? What is the role of them having a more support at a lower level? Because I can imagine this could be for a lifetime. So it could be cheaper, and what you could say to our system as organized now, because not everybody will afford that tertiary institution or the private. What could be your thoughts on that?
Okay. Unfortunately, not getting a diagnosis. Okay, let me start. By the time you get to tertiary, I agree with you. It's the cost and accessibility is not easy. But surrounding yourself with people who understand, surrounding yourself with a community that care gives you the care that you need will actually help. But now when it comes to neurodevelopmental conditions, it's hard because even this cuts across education as well, because a rare disease is not a healthcare issue alone. So it cuts across education. There are no schools for our kids. There are no social areas for our kids. So as much as we try hard to do what we can from the healthcare system, the other systems are also not as supportive as they should be. So it becomes such a struggle and hurdle for a parent to raise their child. I'm going to give you a very sad example. Before, when I used to be young, I used to say, where would you tie your child up and go to the shamba? But as I got my kids and as I got to understand, we all have, especially as parents of kids with intellectual disability, we all have some form of tethering to our kids to keep them safe. If you put a child that has tendencies of running away and you leave them in the house because you have to go fend for them. Let's pick this single mother in the village who has to go dig and make come back with food for the child. She cannot go with the child. There's no one to leave the child with. What does she do? She tethers the child to a tree near the house. And then there'll be a lot of scorning and saying, why would you do that? But what do you expect this mother to do? If she doesn't do that, the child will run away. Or the child, God forbid, will not be assisted by the community around him or her. So it all boils down to community. It all boils down to us being our neighbors, keepers. And I may not get the full healthcare that I deserve or is a right to me as a Kenyan, but management of that or care of that for me to have the best quality of life, I think can be done without having to go to hospitals, because it's hard. And then the sad part is, as Kenyans right now, we are just a disease away from poverty due to Harambes and all that. But then I always ask, what about persons living with a rare disease? There is a condition called spinal muscular atrophy, where the drug is around $2 million a shot. Who's gonna come up with that money? So there's so much that is not, how do I put it without sounding a pessimist? There's so much not happening right, but as a community, as a society, I believe we can easily bring each other up and help the next person, so that at least it's not all dire and they're not all alone.
Thank you very much, Christine. Having seen you in person, I know you are not the people who are there to be pitied, but you are a powerhouse, a woman who's helping others and giving words and meaning to these experiences. And so it helps us, the system, to be able to see what contribution can we do in whichever place we are in. And we truly appreciate the growth of the diagnostic space in the country, both private and public, and that at least enables the diagnostic journey to be shorter. And so if we could just put together what you strongly said, is that as the healthcare, we need to engage with the parents of the children and of the people who are living with rare disease, knowing that indeed the diagnosis has to be made with openness, even to the spaces that we truly are still on the journey, that we need to communicate and to be able to know that they could know more than what we know about the disease. And so you've asked us to engage. And I've added the aspects of ensuring that we're ethical as we look at the financing and such, that we are not just pushing to the next and to the next for the purpose, you say that for financial benefit, but at the same time to be just ethical, that there are costs related to it. And these are people also who are doing this on the side of care, there's a cost. And then also on the side of the diagnosis, there is a cost related to them. And so thank you that you asked us to truly engage, and that we should be the ones to help connect to the community. And so I think for everybody who is logged in today, they are now aware that there is a community. And nowadays everything is just as far as Mr. Google and finding out rare disease Kenya, who can I meet, who can I talk to? And so we also become champions of the work you're doing, and conduits of health that the patients who are coming by our way so require. I'm not a pediatrician or a genetic scientist. I do patient-centered care, and that's how we met with Christine. But this is really at the core of patient-centeredness, matters of communication, disclosure. But now we have fixed the pain point of how tortuous diagnosis can be. And so we need to engage and accept that we are doing this together. When it is, when you cannot do that next test, let us understand the reason why when the next treatment cannot be bought because it is this expensive. Also, we need to be part of offering that care with the empathy and just understanding that this is an opportunity to just humanize this care for this person who is coming with their kin, because they're going back home, continuing to take care of them. And yet this is so meaningful that we reduce their discomfort and reduce the spaghetti steps that they could be making within our institution. So Christine, thank you very much. Allow me to hand this back. Yes, do you have any parting shot? Or I'll allow Dr. Mary to give that before maybe she invites the next speaker. Yeah, I think let me hand it over to Dr. Mary. Thank you.
Okay, no problem. Thank
and
you.
It was a great pleasure having you.
Asante, same here. It was a pleasure being here.
Yes, thank you so much, Dr. Okutoyi and Christine, for that engaging conversation. And welcome to all the new members. I think when we started, we were 200. Now we are at 500. So just thank you for joining in the conversation. We've been talking about diagnostic safety in specifically children, and in this case, specifically in children who have rare disorders. So our next speaker, final speaker, will just give a brief session, a brief talk on the same, on diagnostic safety in children. He is Dr. Stanley Ariaru, and he's the current Chief Medical Officer at PCH Kikuyu Hospital. He's also a general and laparoscopic surgeon who's very passionate about health policy and quality. So this is his area. And so, Dr. Stanley, welcome. Just to add on to the conversation that we've been having, there's Dr. Okutoyi described and defined for us diagnostic errors that happen. And she said that that includes misdiagnosis or wrong diagnosis. And so just from maybe your experience, what would be the magnitude of this misdiagnosis and wrong diagnosis in pediatrics? And, you know, one of the factors that Christine had talked about was that it's diagnosed late, or there was late diagnosis, even from a primary healthcare level, which is one of the conversations we've just had. So how can we also improve our suspicion as healthcare clinicians or the healthcare space? How can we improve our index of suspicion for just any diagnosis, but particularly in pediatrics? Dr. Stanley.
Thank you, Mary. Please confirm that you can hear me loud and clear.
Yes, I can hear you, Dr. Stanley.
Thank you so much. It's my pleasure to be here. Sorry, Christina, I missed much of your talk because of clinical engagements. I had to sneak out of clinic and come here. Thank you, Lydia. Thank you, Rhoda, and the entire team for inviting me. I just want to share a case that I have that is active. And this is a lady in her 50s who has had a breast ulcer for 10 years. 10 years, believe it. She went into hospital and she had a lump. The lump was removed. She can't tell what the histology showed, but the wound never healed. And therefore, year in, year out, she has gone for dressing. And when she came to us a month back, this was obvious breast cancer from any initiated eye, even without examining, even without investigating further. But investigate we did, and we found invasive ductal carcinoma and staged it, and luckily for her, it was locally advanced because the breast was so, the ulcer was so necrotic, you now had to move with a certain urgency to kind of offer surgical toileting as an aspect while still doing modified radical mastectomy for any surgeons in the room. And when I posed back and wondered, so why did this happen? And I'm saying this to link with what Mary has spoken about, the definition of diagnostic errors, because I think that is the bit that was left out, that either the diagnosis is missed, or the wrong diagnosis is given, or the correct diagnosis is delayed. And really there is a very, very, very fine line between and missed diagnosis or delayed diagnosis, because until you get it correctly, then it was missed. So really, whichever way you look at it, you can split delayed diagnosis and missed diagnosis into one category, or you can split them out. So every time I have spoken, especially when you discussing malignancy or any disease in the low and middle income countries, we will say late presentation is a problem. But I think the issue that keeps coming time and time again is that it is not because the patient did not get out of the hospital, out of their home and go to the hospital. It is because the capacity of the first healthcare provider was not at par to give them the correct diagnosis at that point. And if we remember the 6 domains of quality healthcare, then healthcare that is not timely is not quality, because what you end up with is a harmful delay, as the case has been discussed at length. So this keeps being an issue day in, day out. And I know if we opened this suggestion box, and I want to do that now, and just hear people sharing a case or a case or more that they have encountered of either delayed diagnosis, missed diagnosis, or totally wrong diagnosis. Again, it's just an overlap of terminology. I am sure the cases will be as varied as the people on this call. So I wouldn't want to try to give the magnitude, because I might overemphasize or I might underemphasize. But I just wanted to mention a few things, and this is what we spoke with Mary when we discussed yesterday, and then open it to the plenary, because it becomes more granular and more organic if we have case-by-case discussion, as opposed to just me giving a wrap-up of things I've seen. But the first thing to say is that getting the correct diagnosis is not only central to the rest of the care of the patient, whether they are handled pediatric. If you miss it, then you go completely on a tangent. And that is what has been discussed at length. And therefore, for the correct diagnosis then to be correct, it must be accurate, it must be timely, as we said, that it can't be delayed. And there are so many factors that play into this. The factors are knowledge, the factors are experience and skills. Knowledge, experience, and skills belong to the human care, to healthcare provider, that person. So those are personnel factors. And then, of course, you have got the resources that are available to support that person. And then the resources become the tests, the equipment, the reagent, you name the entire supply chain. And now where Rhoda and Mary and Lydia come in is then how do you set processes? And I think that then becomes the angle as we speak about the commemoration of patient safety, and in line with this year's theme around diagnostic errors and how to minimize them, is how to curate a system that actively goes looking for the diagnostic errors and looking at how to correct them. So I think the first bet, like any player in the healthcare sector knows, is our Donabedian model. If we don't populate our institutions with the accurately trained healthcare providers, then we might increase our diagnostic errors, because what a clinical officer can pick is not going to be the same level as what a general practitioner or a medical officer can pick. What a medical officer can pick is not at the same level as what a consultant can pick. And then when you get to the consultant, the next question is what a subspecialist consultant or a specialist consultant can pick is different now based on years of experience and also based on the segregation of care. So I would assume if I work to a center of pediatric care excellence, then the rate of diagnostic errors in that institution is going to be exponentially lower than if I just walked into a regional facility that does not have a specific specialty. So this is a calling for us where we are in our various segments of the healthcare. Those who work in tertiary areas, this is something you could push. Those of us who work in the primary care areas or in low tier tertiary level facilities, then is how do we pick quickly and start counting? For me, I think counting is the issue. Counting the diagnosis that we are missing because we don't have the support or because we didn't have the capacity, and then making that data help us make a decision. So I think that is the second point I wanted to make. And the third point then is on the centrality of the electronic medical records, because previously when you talk about patient safety and when we talk about quality and talk about minimizing all errors, be they diagnostic errors or medication errors or whatever, the doctor and the nurse have historically been at the center of that conversation, and they have been the key movers in that link. They were the links in that chain, and they were the key movers in this conveyor belt. Now enter the electronic health records, and now you introduce a different category of people. That is the ICT, and that is the supply chain for your gadgets. So now you are no longer asking, do I have a competent nurse? Do I have a competent doctor? And are they thoroughly trained, and have they had refreshers on what to look out for? Now you're asking, how strong is your internet? How strong is your VPN so that you don't breach data? How human-proofed is your system? And on this, I have had so many instances because we've just clocked 1 year with a new HMIS, beautiful system, but like we say, garbage in, garbage out. So until you control so tightly, then you find a patient whose hemoglobin has been input as 1.2 instead of 12, or 42 instead of 4.2. So you miss anemia, and because the system didn't have a way to lock the human interface to within certain confines of accepted range, then you could easily miss a critical value. And this is real life situation that I have fought with in my institution as we try to streamline and fix all the bugs in the system that we are running at the moment. One day you do a ward round and you find a patient potassium indicated as 41, and obviously it can't be 41. So you stop everything, you go pick the ICT person and you take them to the lab and you tell them, fix this, let me not come back and find this. The following day, you find a temperature is written that 355. Again, because you fixed it, but there's a bug in the system, it didn't lock it such that as long as the temperature is entered in degrees Celsius, it surely cannot be less than 2 digits, and it cannot be more than 3 digits for a patient alive in the tropics. So these become the realities that force us to quickly start thinking, how do we make our electronic health records sacrosanct, both to protect from human error of entering wrong digital data. Number two, how can we use it to pick quickly? For instance, the system we have is very, very, very good in alerting the doctor. I am seated in the clinic, I have a long queue, but the moment there is a critical report from the lab, it pops up on my screen. So I can't even see the next patient properly because I'm quickly informed there's a patient here who is having severe anemia, there's a patient here who is having extremely high potassium. You have to see this patient immediately now. So it has its good parts, but we just have to be vigilant, absolutely vigilant, to make sure that the system helps the human and the human does not become a little lousy, drop the guard, and then start keying in wrong information. So I think that is something I would like to hear from the team on the call as well. How has their experience been? But I think that is a new frontier in terms of how we are pushing this going forward. Now, the question that was pushed by Mary is different, is a little different. How do you deal with this, and how do you work to minimize diagnostic errors, especially in children? And there are various ways. Again, we said there are human and cognitive factors that contribute, and then there are system factors, and the system are dependent on the processes and dependent on the resources. So a lot of things have been, discussed in terms of how do you improve from this point going to the next. And one of them is to look at, I can become a little more of, really research oriented, but one of the things that have been looked at is actually medical record review that is planned a priori. For instance, if we always have a schedule of mobility and mortality meeting, but the quality team that is just focusing on patient safety and diagnostic errors might decide our audit is going to look at the digital records and see, out of the 10 patients we saw, how many diagnoses did we miss from the time they got in to the time they left? Because now we are agreeing diagnostic error includes a delayed diagnosis. We don't have to wait for 5 days for the major ward round for us to find we lost it completely. We lost this at the admission desk, and now we are picking the diagnosis when it has complicated. So then once you start this, you start creating a small mind shift to the front team and the middle level team leaders, who then know this is something that we regularly report. Every time we come, sit down and look at it, we regularly report. Yesterday, I had one of the assessors, and one of the things we are looking at, she asked me, come on, pull up your electronic health records and show me, for all these patients you operated, where are the anesthesia preoperative notes? And as the Murphy's law goes, the moment I opened the first patient, I missed the preoperative review because it's now digital. I missed the preoperative review because once the anesthesia reviews the patient, they need to input it like an entry. And then the moment we go into the intraoperative monitoring, as long as they input, the system automatically feeds into the anesthesia chart. So that was easy to get. So now when I get back to my head of anesthesia and the safety team, I tell them, guys, tell me how we had a patient who went in without anesthesia review. Because yes, anesthesia review may have been done, but the retrospective chart spot check shows that there was no anesthesia review. So every day then, if there is someone who is tracking this as one of the data you track, then it becomes easy to quantify and say 10% of our abdominal pain is missed, instead of being treated as UTI, is treated as gastroenteritis, or vice versa, and then you can create a work improvement around this area. The other is the complete ballistic side of it, which is just to analyze the malpractice claims. And this has been pushed forward as one of the things you can deal with, including in adult and in pediatrics, because when you have a malpractice suit, or when you've family that is complaining, definitely there is something amiss with the system, whether it is the experience they went through or whether something missed. So if every time we have a complaint from the family, we quickly launch it, we do a root cause analysis and find out, why are they saying there's a malpractice? Why are they saying there's negligence? Was it because we missed, or was it because our treatment failed, or what happened? This can become another gold mine, as posited by research, where you can pick those diagnostic errors and keep going back and improving. Of course, those of us in healthcare will always, every time you have really a difficult case and you've lost a patient and you're doing a root cause analysis, we are always asking family, can you please give us a chance to do an autopsy? Now, this is the extreme end, because it will happen. We will lose patients because we missed the diagnosis. Of course, we went with the best interest of the patient at heart. We had all our scans, we had all our investigations, we treated what we knew. And until you are given another diagnosis, you will always stand with your diagnosis, because that's where the end of your capacity reaches. But if we are slowly able to pause once in a while and say, okay, go back to the pathology department, come back with all the autopsy reports, because that is the legal, that is the medical legal, that is the forensic, that is the definitive diagnosis that says the cause of death, fat embolism, cause of death, thromboembolism, pulmonary thromboembolism, cause of death, missed injury, for instance. If we then went back with these records and looked back, we are also able to say, for every patient who presented with this kind of characteristic and we lost them, we realized we had missed this diagnosis. And the beauty with the electronic health records is if you have a robust IT team, then they're able to do extensive metadata analysis in the back end and tell you, you can even create algorithms and projective or predictive models for this patient who comes like this, and they're not improving within this period, think about this. So that is another thing that has been raised in literature, and it's a challenge for all of us to ask ourselves, how often do we descend on our pathology department and tell them, give me all the pathology findings or autopsy findings for all the inpatients we've managed for the last 1 quarter. Let me now do the pathologist to the clinician corroboration and find a solution to it. But of course, what is more popular in the quality setup is what we call the incident reporting systems. And I think this, we can challenge ourselves to say, how can we improve on the incident reporting? Every time we have a missed injury, it is very easy to raise an incident because that is an acute event. But if someone came and we are treating for gastroenteritis and then we realize it's pancreatitis, or we are treating for sickle colic and we realize it's urinary tract infection, how do we raise it as an incident to push our bar so that we have the correct diagnosis by the 48 hours the patient in the hospital or something like that? So again, that is an area we can look at for all of us who have the incident reporting policy, we have the incident reporting tool, and you have an incident register. You could actually push in the clinical incident to capture a missed diagnosis or a delayed diagnosis and follow through. And then the drivers who are really physician quality leads are able to look through them and call their colleagues to order and ask them, what is your take on this? Because then we are missing this diagnosis every so often. And then you come up with a corrective action every so often. I remember, I think a few months back, I noticed that every time we have a surgical patient, especially when our residents were on a break for their exams, there are quite a number of interventions that are missing for the obvious bellwether surgical issues, and especially trauma. So you see the patient, yes, they have a CT scan head, but you ask yourself, so where is the cervical spine X-ray, or where is the cervical spine immobilization, and you miss it. And then you ask, how can it be that we have someone in casualty who missed this crucial information that could have been started before the consultant maybe comes in the morning? Because when the consultant comes in the morning, if the patient was fairly stable, they probably were not notified until they came in the morning, and then they realized this and this too should have been done. So once you quickly analyze that, we decided, you know what, we will do a refresher trauma course for all our medical officers and tell them, until you have this, your appraisal is not complete, and we copied in the HR into that, just to try and create. So there's a lot of data that we can infer on a day-to-day basis. And then once you have all that, then you can look at how you learn from those and then start strategies that reduce the diagnostic errors. And the strategies, again, are going to be system specific. In equality, we always want to blame the system, asking the proverbial 5 whys. Why did the person miss it? It's because they are not comfortable. Why are they not comfortable? They have not had a refresher on this. Why have they not had a refresher on this? Because our budget from HR is not catering for it. Why is our budget from HR not catering for it? Because it was not requested during the budgeting cycle. Why was it not requested? I'm just giving an example. So you can go all those whys and identify the root. Forget the branches, forget the stem, the root causes of why this is happening. And therefore, you can do what is called individual or cognitive-based interventions, where you are dealing with specific individuals, because again, you can track and say, we have these issues. And I want to give the final example as I wrap up. We had quite a number of concerns from our radiology department, where consultants will say, can I get a consultant radiologist to do this sono? And we ask, but this is not specialized ultrasound. So what is the issue? And then you'll be told, this scan missed DVT, this scan missed an impeding abruptio, this scan missed the other. And therefore, when you ask, then you come into that dicey space where you ask, is it a capacity? Is it an attitude issue? Or what is it? And you are told, but this person also works in this level 6 tertiary private facility. So how can he or she miss? And therefore, the easy bit was to tell the in charge, raise the incident for every complaint that comes from the consultant, log in, log the issue, and log with the affected person. So then when you come back, you can see all the complaints that have been raised about staff A are because of capacity. All the complaints raised about staff B are about attitude. Once you have the causes, then solution is easy. So they are cognitive and individual-based interventions. And then the others are the system-based interventions. And this is really the bread and butter of quality improvement, because every time you're doing a root cause analysis, every time you are looking at an incident report analysis, every time you do your M&M, which is scheduled, every time you have a near miss or a sentinel, when you analyze and microprocess it, then you come up with a system issue, because it could be Stanley today, but all systemic factors held constant. If you pluck out Stanley and replace Stanley with Lydia, Lydia will suffer the same misfortune. So again, there are all those system-based interventions which I don't need to look into, and then you are able to look at them. Of course, a lot of these things, once you have these solutions, then you tweak them to pediatric, because pediatric is a little different from adult. The pediatric patient will not complain to you. Their mother might not feel what it is. So when you're talking about empowering the patient and telling them how to interpret their results, the little kid will not know that. It is probably the family who will help them. So in a nutshell, these are more or less the things I thought I would just highlight as areas we can, think about on our feet. But I am told, Mary, it would be easier if we just open this into a plenary sharing session and just add from the wealth of experience from all the people who are logged in as listeners or panelists. I thank you, and I hand it back over to Mary. Thank you so much.
Yes, thank you, Dr. Stanley, for the explicit and wide conversations that you've brought up. You've really talked a lot about systemic improvement for us to be able to improve our index of suspicion as healthcare workers. You've talked about training, research, even you've talked about electronic health records. And I'm just curious to know, amongst maybe the healthcare workers who are here or people working in the healthcare space, how many people have, the electronic system, and how many people do have also the, Dr. Ariyaru, you've mentioned incident reporting, like for us to be able to report where we have errors that we can pick in the system. I'm wondering how many of us have that. I think that's also something key that we need to pick up as healthcare workers in whatever space we're in, to develop and to come up with, or to amp it up if it's already there. Yes, so thank you so much to our speakers. Just quickly go through some questions. Most of them, thank you for asking questions. And kindly, you can continue asking questions if you have any in the Q&A section, which is just down below. Most of the questions have been answered, but there's a question by an anonymous attendee that was directed to Christine, and Christine gladly answered. Thank you. I'd like to turn the tables a bit to Dr. Okutoye and Dr. Ariyaru to be able to ask and the same question now from a healthcare point of view. So the anonymous attendee asked, Christine, I love how you've put it, that you helped the doctors help your daughters. That's something we really need to learn into, lean into as a profession, truly listening to the patient. Have you or any of your colleagues noted any resistance to such input from healthcare workers? That's one question. So just from a healthcare now worker point of view, thank you, Christine, for answering. But from a healthcare worker point of view, there's that issue where we are sometimes as healthcare workers resistant to what the patient is bringing or is saying, and especially from a pediatric point of view. Dr. Stanley, you've mentioned that pediatrics patients or children, they don't really complain. Mostly it's the mother or the father, whoever the caregiver is, who comes up with maybe the symptoms, and they're the ones who tell and bring up the complaints to the healthcare providers. So how can we change the system so that, and what can we do as healthcare providers so that we're in a better position to listen more to the patients that we have, so that we even get to a point of making this shared decision making, so that the patients also don't feel like they're not heard. Yes, we can start with Dr. Stanley.
Thank you, Doc. If I get you correctly, I heard what can we do to make sure that we involve patients more and more? And it is for me to say, again, when you look at the Global Patient Safety Action Point, one of the guiding principles is to engage the patient and their families. So when the patient cannot talk, whether they are pediatric or an adult critical care patient who is in ICU intubated who cannot talk, then I should be able to talk to their next of kin and also play the advocate's role. Just last Thursday, I had this heated call from my team in the orthopedic wing because there was a young child with a sarcoma of the thigh, highly aggressive, and now it had busted, it was bleeding, and they had promised the mother that this girl needed amputation, but the mother completely refused. And when now it was a life and death matter, they were stuck. Where do we go? And what do you do when the next of kin has come and said, no, you are not touching my daughter's leg over my dead body. I don't care whether the sarcoma is threatening to take away her life. So the only art you can wear at that point is just being the doctor's advocate. And I remember at that point, us engaging really our legal team, engaging even the nearby police, because it's going almost the essence to the angle of, criminal negligence really for a next of kin who is a mother of all the others to deny and decline medical therapy, despite them signing those documents, which almost all of us have discharge against medical advice or refusal for medical treatment or leave against medical advice. Whatever you baptize your form, they sign there and you move on. But then you pause and say, okay, fine, the system is covered. But as a doctor, I am supposed to be the patient's advocate. So I would again cycle back to what I had when I joined on the call: advocacy, advocacy, advocacy. Because advocacy means we may seem that we have exhausted what is there legally, but how have we gone out of our way? So I remember us engaging and trying to go raise an incident and an AOB so that the police would come and see if this is a criminal case, and even alerting the medical board and telling them, we are stuck. Yes, these are the people who will probably come and sue Stanley or sue the hospital because they say you should have told them, but we are telling you and you have refused. You have had a counseling session with our psychologist and all that. But anyway, luckily the mother agreed finally after lots of frustrations. So I feel the point you're making is the advocacy. The advocacy cannot be overemphasized. My colleague who is a surgeon had a dad who was a pediatrician. And the one thing I remember him telling me about his dad every time we went to see his dad is that his dad never used to waste time with the patient. A baby would be brought, they are sick, he makes a diagnosis that this is severe pneumonia, or this is meningitis, or this is gastroenteritis with severe dehydration. This is an inpatient patient. He puts a cannula, he hangs the first drip, and he carries the baby to the acute room of the admitting ward. The rest is none of his business. Let people go there and actively carry the patient back. Of course, that's a little brutal. It sounds military and all that, but I felt, okay, this is really being a patient's advocate. So I don't have a magic bullet to answer to you, but I think if we said, let's be patient advocates, we will know the nuances about our institutions. We will know that if you go to the admission desk and you queue there, it will take you forever. Let me go with this form and get in through the back door because I have a name tag. And if I leave you knowing our system, you will be in the OPD for the entire 12 hours at night. So each of us can now tweak our systems and say, how have I managed to become this patient's advocate without passing the buck? And the same goes even as you do diagnostic error, and assess the incidents and assess the data, then you're asking yourself, if we had one patient getting their diagnosis right, that is already one too many. And once that starts going in, then it becomes really easy. I remember in Meru, our CEO at one point wrote an email that said, I don't care whether your mother's fixed rate is below the timings or below the statistics. Someone walked in here and they are going with a baby who is not completely healthy from our maternity. That is a cause for concern. So I think I could rattle on and on and on, but I think it's important. Maybe others can also give their input. Thank you.
Thank you, Dr. Aro, for the input. Yes, Dr. Okutoi, you had raised your hand. Did you want to say something?
Thank you so much, Dr. Yeah, thank you, Dr. Ariaru, for those comments. Indeed, I think being the patient advocate is very, very important. I just wanted to highlight some that there are some communication styles that enable us to ensure that we are involving patients in decision support and what we should do and what we should not do. So I guess if a young surgeon works with Dr. Ariaru during counseling, the words they use, how you remove the medical jargon and make it in a manner that the patient can understand and allow talk back, like what do we understand? What is the take home? Then you're able to know, are you moving together with the patient? And just from a human point of view, understanding what could be their pain points so that when you're communicating about a process of a decision making, you confirm that those potential points of disagreement, they are truly understanding. And we found that many times when we have ethical dilemmas or when people are refusing care, there are times we've not just given the full disclosure of what is expected from them. So how do I live from here? So what will be the cost of this treatment? How long will it take? Will it cure or will it just reduce the pain? So a big portion of diagnostic errors is alluded, the underlying issue is communication. And so how to communicate, and communication means that we listen to the patient and observe how they react to that information, to the family, and what are the issues that would need further clarification, or in their body language, what do they seem uncomfortable with? And then also open it up that they are free to come back. We can discuss this further. So just understanding that this is heavy. So I think this is modeled, and the more you have experienced several patients and families, the easier you can preempt it. And so the approach is, if the younger colleagues could be modeled by the older ones, and ensuring that there is time. There are patients you can walk over very quickly and finish because they are known, you know what you're handling. But there are those whereby everything stops, you put your phone down, and you talk, you don't even write, you talk and listen to how they're responding to what you're saying. So I think communication techniques need to be taught, need to be modeled, and we need to get the feedback from our patients, how we are doing as far as having this discussion. Then now we will be able to go to that point of having shared decision with our patient, because you cannot have a shared decision if you do not understand, and if you are doing it under duress. And there are points whereby we give them evidence. So we should digest the evidence to a level that they can understand. We do not cue it because this is what we prefer. And then we remove our bias in it. We come in with bias because of what we have seen, because of the system. So in case there is a bias, we can disclose it, that this is my bias. However, ABCD and the other is the reality. So just knowing that we also come in with lenses that are tinted. Yeah, so my main point about shared decision with the patients is about learning how to communicate and practicing it, modeling it, holding the younger ones to account, and it's becoming a point of learning. Like, we have today, I hope you picked how to communicate. I hope you saw that this made it easier for the family or the patient. I think that's the main contribution. And thank you, Ariaru, for bringing up powerfully the advocacy part.
Yes, thank you, Dr. Choi. Yes, and thank you for also highlighting communication, because the way we communicate that diagnosis can also lead to diagnostic errors. We need to communicate it in such a way that the patient and the caregivers understand what we are doing, and so that we're able to move forward together. So thank you, Dr. Choi, for highlighting that. Thank you also for the questions. I think one of the questions which James Kimori had asked concerning alcohol. So he asked, do you come across patients who have chosen to abuse alcohol or drugs after they discover that they have a rare disease? Thank you, Christine, for answering it, that yes, there's such there's such cases, and just emphasizing on the role of holistic care, that once the diagnosis has been made and we've diagnosed the patient, well, the next step is usually holistic. We need to look at them not only from a clinical point of view, but also from an economical, mental, social, even educational point of view. Just wondering if our systems and our hospitals really support the holistic care and not just the clinical care. So thank you so much for that question. There are other questions that have been asked, but some, for example, by an anonymous attendee: is it lawful to terminate a pregnancy once genetic mapping shows potential advanced congenital abnormalities? Thank you for asking that question. However, this is probably not the best forum for us to answer this question. So we'll just urge you to keep up with us for the next sessions on maybe genetic mapping, as well as termination of pregnancies. But thank you for the engagement. I hope you've learned a thing or two concerning diagnostic safety, how we can improve diagnostic safety in our institutions, And also for the people around here who will be either a relative to a patient or the patient themselves, it's good to speak up and be a patient advocate, just like Christine has done. So thank you so much, Christine, for joining us and for all the work that you're doing. Thank you for even sharing your insights and your experience, and we look forward to having you once again in future. Thank you, Dr. Stanley Ariaru, for the great insights on the systemic improvements that we can make. And thank you also, Dr. Lydia Oktoi, for the great insights, as well as the conversations also on communication when it comes to diagnostic safety. So with that, we will come to the close of this webinar. I'll see you in the next patient safety series webinar. Thank you.